Today let us deal with something that is going to be very commonly used in ophthalmological practice. Whether you're a newly joined PG, a fellow, or a full-fledged consultant or a practitioner of ophthalmology, classification or grading of cataract is something that you are going to do on a very frequent basis. Cataract forms the basis of ophthalmological practice, so let us see if we can simplify the process of classifying a cataract. The very first way to do that is by using something called a pen torch or a gross method. And as mentioned, it is a very gross method of identifying the type of cataract. This method is useful if you are in a screening camp, if you just have a torchlight or even the cell phone flash that we have. So the way to classify is to identify either it is a clear lens, an immature cataract, or a mature cataract. How do we do that? Normally, when we see a clear lens, it is a very dark gray reflex that we get. Why do we not get a red glow, which we get from the fundal examination or when we're doing a retinal examination? That's because the light that we use in a pen torch is very diffuse. It is not focused enough to fall onto the retina. It undergoes scattering starting from the tear film, then the cornea, then the aqueous, then the lens itself, then the vitreous. So it has very little focused light reaching the retina. Hence, a clear lens is going to appear dark gray. Why not black? Black indicates that the pupillary space is completely empty or it is filled with a very transparent structure. The lens is not 100% transparent. It absorbs some of the light and hence appears a dark gray in color. If you see a black reflex, it either means there is aphakia, which could either be post-surgical, post-traumatic, for whatever reason, or it means there is an IOL, a pseudophakia. The next is an immature cataract, which will appear slightly lighter. Why does it appear lighter? Because it doesn't allow as much light to pass through the pupil. It doesn't allow as much light to go behind the lens and have a darker appearance. An immature cataract can be classified into an early or an advanced, and that entirely depends on a subjective grading. Please understand, cataract classification is entirely subjective at the moment. There is no objective method. There is no clinically useful method that is going to, for 100% of the times, classify cataracts into different types consistently. It's still a subjective method, but it does not matter as much. The subjectivity is not much of a concern, which is what we will understand in a couple of minutes. So immature cataract can be classified as early or advanced. The early immature cataract will resemble a clear lens, whereas the advanced cataract will resemble a mature cataract. A mature is going to be a completely white, looking, a lens. And if it is a milky fluid filled kind of a thing, if you see, there's no fibers appearance, there's just a milky fluid, a uniform fluid-like appearance, then it is very likely to be a hyper mature cataract. Now this is what the gross or the pen torch method tells us. Let us look at some objectivity which is introduced by the Lens Opacities Classification System 3. And what LOCS, that is the LOCS classification, does is it divides any cataract into three components. It describes the cataract in three components: a nuclear component, a cortical component, and a posterior subcapsular component. Now this is done because these are the three most visually significant and most common components of a cataract that are visually disturbing to the patient. The nuclear is further classified into an NO, that is nuclear opalescence, also known as nuclear opacification score, and a nuclear color score, that is an NC score. Both correlate with the hardness of the cataract, both correlate with the degree of the cataract, meaning higher the opalescence and higher the color grading of the cataract, harder it is likely to be, but it is the color that is more frequently found to correlate with the hardness. So a darker color signifies that possibly the cataract could be of a harder grade. How does that have implications on your surgery? If you're doing an SICS, a manual SICS, your tunnel has to be larger size. Your CCC, your capsulorhexis, or capsulotomy has to be of a larger size for the nucleus to come out of it. If you're doing a phacoemulsification surgery, then your energy requirements also go up. Consequently, the corneal endothelium needs to be appropriately protected as well. Cortical grading and posterior subcapsular grading is pretty straightforward, as we will see in the next couple of minutes. Let's look at the nuclear grading. Now, for each type, that is nuclear, cortical and posterior subcapsular, for the ease of understanding, we have assumed that that is the only type of cataract this patient has in the diagrams, meaning if I'm talking about the nuclear cataract, there will be no cortical component or posterior subcapsular component in this patient. Ideally, cataracts do not happen in isolation, meaning just a nuclear or just a cortical or just a posterior subcapsular. It is usually a mix of the three that the patient presents with. But for the ease of understanding, let us see if we can classify them on a better note. So nuclear grading goes from NO1 NC1 to NO6 NC6 being the highest grade. NO1 being the least opacification, NC1 being the least color, and similarly NO6 and NC6 representing the highest grade. Does NO1 always occur with NC1, and meaning does NC1 always occur with NO1? Not necessarily. It is not a rule, but it is generally followed that the opacification and the color of the cataract usually coincide in the same grade. So NO1 will be slight opacification, NO2 will be a little more yellowish appearance, NO3 will go towards ochre, NO4 will be orangish or amber, NO5 becomes brown, and NO6 becomes a completely black cataract. And if any cataract lies in between these two grades, say for example it's yellowish ochre, or if it is orangish brown, then we would probably denote it as an NO4, NO5, NO4 to NO5, grade NO4 to NO5. The cortical component is simpler to understand. For this, you need to understand that now this is a slit lamp method that we are doing. Even for the nuclear, why do we have a cut section is because these examinations, these classifications require a slit lamp, and you make an oblique slit and examine the nucleus. For cortical and posterior subcapsular, what you need is retroillumination. What does retroillumination mean? Basically, the illumination and the visualization axis are parallel to each other, are coaxial. They are in the same axis, with the result that whatever light falls onto the fundus is reflected back, and you get what is called a normal fundal glow, which is usually described as orange or reddish in color. Please remember, the fundal glow is not because of the retina, it is because of the choroidal blood vessels, choroid being the most vascular structure of the eye. The choroid is reflecting back the light, and that choroid is giving the fundal glow, not the retina. Retina is normally a transparent structure. Cortical cataract is represented from grades C1 to C5, C1 being a minimal distortion of the fundal glow in the periphery of the lens, C2 being a little more, C3 is when you start seeing these spokes, these cortical spokes. C4 and C5 denotes progression, C5 being the highest grade of cortical cataract that you can have. You can also possibly have a cortical cataract throughout the lens, which means all these spokes converge, all these spokes coincide such that no more spokes are seen. It is just a black retroillumination reflex that you get in the periphery of the lens. Let us look at posterior subcapsular. This again requires retroillumination. Grades are from C1, which is a mild disturbance of the fundal glow, C2 being ochre, C3 being light gray, C4 dark gray, and C5 being a completely black reflex. For copyright purposes, I am unable to show the actual images of the eye, but these images are easily available on online search engines, so I would recommend you go and actually look at how the eye looks like. These diagrams are just a representation. Now, besides these two, there are two more types of cataract that you need to understand. One is something called a posterior polar, and these are beyond the classifications that we normally use because these are not normally seen. These are very, very rarely seen cataracts. Posterior polar basically has an onion hole appearance. It is very easily mistaken with a posterior subcapsular cataract. The difference is that posterior subcapsular cataract does not involve the capsule. It is a subcapsular, just beneath the capsule, whereas a polar cataract involves the capsule. So you need to be extremely careful when you're performing cataract surgery on such patients, because the posterior capsule is just 4 micrometers thick, which is the thinnest part of the capsule, the entire capsule of the human eye. So 4 microns thick with a posterior polar cataract makes it very, very sensitive to trauma. So it is very easily confused with a posterior subcapsular cataract, but gives something called an onion hole appearance. The other one that you have to remember is an anterior subcapsular cataract, also rarely seen, but appears similar to a cortical cataract, but just in the center and just beneath the anterior capsule in the visual axis. One thing before I forget, can you have an isolated posterior subcapsular cataract? Yes, amongst the 3 types, that is nuclear, cortical and posterior subcapsular, if one has to occur in isolation, the most commonly seen is a posterior subcapsular cataract, which is seen very often in a steroid induced cataract. So which mode of steroid will cause this? Which route of entry of steroid will cause this? All modes of steroids can cause cataract and all modes of steroid can cause glaucoma. But it is commonly seen that oral steroids are more commonly prone to produce a cataract, whereas topical steroids are more commonly prone to produce a glaucoma. So why do we need to grade these cataracts? One is a very practical reason. When you're learning, you would want to have some immature cataracts, because if your tunnel is smaller, if your rhexis is on the smaller side, then a smaller grade cataract can be better managed than a larger grade cataract. So in your residency training, your fellowship training, a smaller grade cataract is generally preferable in the beginning. The next is research and academic interest. If you want to see if a higher grade cataract surgery produces more corneal edema or produces more anterior chamber inflammation, so on and so forth. So a research or an academic interest is why you would want to classify cataract. But do you really need to know the grade of the cataract? The treatment is eventually surgery. Yes, the parameters vary. A higher grade cataract will require more energy than a lower grade. But does that really bother the surgeon? Ask any good phacosurgeon and they'll tell you that even if it's just 5 or 10 minutes before the surgery that they get to know the grade of the cataract, they are able to manage the case very, very well. So the point of these gradings is to not worry too much whether this is C1 or C2. Worry too much whether this is C2 or C3. The point is to make sure that we don't confuse a C1 with a C5 or a C2 with a C5. Similarly, the point of nuclear opacification and nuclear color is to make sure that we don't confuse a grade 2 with a grade 4 or a grade 1 with a grade 5. Those kind of things. So we want to know the trend. We don't want to exactly know what grade it is, but we want to know what range it might fall into. That is why very often you will see ophthalmologists noting the grade of a cataract as an NO4, NO5, NO4 to NO5 or NO2 to NO3. They will not give a single value because ideally you're supposed to have a printout of the LOCS system, of this lens opacification classification system in your OPD just next to the slit lamp where you're seeing the patient, and you are supposed to immediately compare what you're seeing with what the standards are. You can understand in a health camp of maybe 100 screening patients that are there, it would be very, very difficult. So an error of judgment either here or there of a little variety is acceptable. So that is how you would talk about the lens opacification classification system number 3 and the torchlight examination. So the next time you see a cataract patient, which you will if you're an ophthalmology resident, fellow or a practitioner for certain, please try to incorporate these practices and see if it makes a difference in the practice that you're conducting. Thank you so much.